can do that. So Kemi Johnson, I'm not sure if you have her bio. I wouldn't normally read it out, but I will just in case you don't. So Kemi Johnson, birthkeeper, birth consultant, formerly a registered midwife in the UK. She's been a birth activist since her health and that of her child were impaired by an unnecessary induction almost 30 years ago. She's passionate to assist families to avoid iatrogenic harm. And she says the over-medicalisation is a nightmare that we all need to wake up from for the sake of the future health of all. So over to Kemi. Kemi, I'll give you a 5-minute warning.
Yeah.
Okay.
Thank you. So good to see you all this morning. I'm going to try and share my screen without messing everything up. So won't be a second. Right. View. Slideshow. Right. Can everyone see that?
Yes, we can see it. That's worked great.
Yeah. Yeah. Okay. Brilliant. Brilliant. So I've called it failure to wait. What I'm talking about, and I think I'm in a good position to speak on this matter because I've always waited. So I've been very fortunate as an IM to have group parents that have always been willing to wait for spontaneous labour. I feel really fortunate because I know that so many people haven't experienced these days of intervened with birth, and so they don't have in a person's ability to birth. So I completely know that I'm in a very unique position to be able to speak about the many hundreds of births that I've seen that have unfolded spontaneously between 34 weeks and 44 weeks. So I've seen whole span. When I think about waiting, my waiting includes a memory suite. So I am in quite a unique position. Hopefully, it says my internet connection is unstable. Hopefully you can still hear me well. Let me know if you don't. But, so I am in a very, very unique position. So I really am so thankful for getting the responsibility really to kick things off, following Sue down on what spontaneous birth actually looks like and the gifts that it gives to us as practitioners as well as to the parents that are having it. So I said the sabotage of perfectly good birthing because in all honesty, what I mean is that physiology and the psychology of the family really have got this in the vast majority of cases. There will be the occasional time when birth has started spontaneously and then I need to perhaps recommend transfer for the birth to be completed with more medical assistance. But still in most cases, you'll see that the baby is vaginally born with minimal interventions because in most cases, the people I'm looking after have prepared a birth plan to take in with them to the hospital just in case they need some assistance. And we still get to tick off most items on that birth plan. And most items on the birth plan, because they've had the continuity of care from me and others that I might recommend, will normally include physiological processes. So the confidence of the family to wait and then to allow the process to unfold is heightened by having a continuity of care from people that actually trust the process and understand the process. My level of understanding isn't, deeply scientific. So when I'm speaking to you over the next few minutes, I'm encouraging you to go and find out why the things I mention unfold in the way that they do. And you'll see I've also mentioned the circle in my presentation because that book, I've read it in the last year and it confirmed so much of what I'd seen unfold just by walking alongside families as they give birth and then go on to nourish their babies from their bodies. So it's a groundbreaking book. I think every one of us that supports families in whichever way needs to read it. It is not an easy read because it is bulging with research and science So it's not an easy read. It will take a while to wade through it. I particularly mentioned in my presentation chapter 2, which is Kirsten Uvnes Moberg and Sarah Buckley, because they talk about the physiology that unfolds as a result of hormonal shifts and changes, the hormonal cocktail. Amazing. There are so many books being produced by many people, probably even in this conversation, that are so groundbreaking. And I just have to say right now, I'm quite upset that we have all of this information, that we have all of these midwives, research midwives, people producing excellent work, peer-reviewed, published in major journals, that is still being ignored by people that call themselves birth workers. So, and it's inexcusable. If we are, saying to families that they can trust us, it's inexcusable that we don't understand how birth works, even on the level that I do. I understand it on a basic level, as in I see it unfold. But it's unforgivable and inexcusable that in this day and age we are still using brutal techniques to get birth done, when in actual fact, if we left it alone and only helped when we were supposed to help, just like what Sue just said, if we could just competently take care of the majority of women that are and birthing people that are healthy, carrying healthy children, if we could do that, then we'd have some great stats in this country. But because we can't do that, our stats are getting worse. Our induction rates are rising, instrumental birth, cesareans, some of the infographics that are being, published in social media, where you only got and at a home birth, you've only got a 50% chance of having a physiological third stage. That's shameful. So I just having to say, every day that we're having families having dramatic births, we are midwives, most of us that are here, midwives and birth keepers. We are doing our best, but we need to encourage many of our colleagues to do much better than they're doing, because it's having an effect on future health and the current health of families. And it's having an effect on their finances, their livelihoods, their relationships. So, sorry, I will move on. So, just want to think about the word spontaneous. I'm going to share some stories of what I've seen, but I just want to think about the word spontaneous. And I've just put some meanings, some definitions here. Let me just see. Right, so the first one, happening or done in a natural, often sudden way, without any planning or without being forced, okay? Happening, especially in a living thing, without being caused by something outside or without the organism's control. Happening naturally without planning or encouragement, right? Some definitions of spontaneous that I found. I actually pulled up on my phone the Cochrane review of membrane sweeping that was published in 2020. So the title, Membrane Sweeping for Induction of Labour. So we can see straight away that the Cochrane review, those that participated in it, agree that membrane sweeping is an induction of labour. And yet you will see that many, many parents are told it's not. And the confusion is quite alarming, because then in this Cochrane review, the update in 2020, they actually say, let me see what it says. Okay, in the key results of the abstract, compared with no intervention or a sham sweep, 40 studies involving 6,548 women allocate to membrane sweeping may be more likely to have spontaneous onset of labour, it says. So we've got the membrane sweep being acknowledged as being a method of induction, albeit induction light, or sometimes they're called an informal induction. So they've said that that's what it is, and they've concluded that in the title of the paper. But then they've gone on to say that it leads to spontaneous onset of labour. So you can see we really do have a big problem with perception of what is spontaneous in this country, which again ties in with something that Sue said earlier, which is that it's really odd that people would be talking about their natural birth. And then when you just dig just a little, you'll find that they've been swept, or that they've had more formal inductions, like, you know, some prostaglandin pessary or some other action, or, you know, they've got all these other things now, like the balloon induction and, you know, all sorts of things. So they would have had these things happen. Of course, it will affect the way labour unfolds, and I'll go into that a bit later, but I don't think I need to go into that much. We know it will. But then it will be natural labour that will get the bad rap, not the intervention. So just want to look again at another aspect of this, to induce. Right, so I just found a couple of definitions on there other than the blatant, because now everyone knows what an induction is, and everyone kind of expects it to be a thing that will creep into most births for whatever reason. We've got an increasing list of them. I don't need to go into them. I'm sure some of you will later. But I'm now hearing that, you know, with Group B strep, with that, you know, women are being advised to be induced. It's incredible. I don't see how Group B strep positive can lead to an induction. I'm confused. So anyway, to induce, to persuade someone to do something or to cause something to happen. So that's what's happening. I think the last time I saw the journalists having attention on our induction rates, was it in 2017 or something, when they noticed it was 39%? Something. But anyway, what I'm hearing now is in many units it's in excess of 40%, so we're approaching 50%. To persuade someone to do something, I'm sure you'd all agree, those of you that actually work with families, there's a lot of persuasion that's going on. I tend to call it coercion, which is illegal, but that's happening to cause something to happen. How are we causing things to happen? It could be even psychologically. How are we impacting the psychology of families and their ability to wait with the words that we use and with the pictures that we paint? And, you know, the term we often use, the dead baby card, being thrown around in the conversation. So we're persuading women or birthing people to end their pregnancies. And many of us are. I doubt it's anyone in my hearing that would be doing that, but how many midwives are there in the UK? Is it 34,000? So there's a lot of persuasion and coercion going on with families. They feel led to end the pregnancy for whatever reason. Could be too fat, too thin, you know, it could be anything that they're coming up with now. Oh yeah, abdominal circumference. Yeah, so that's a current one at the moment. Abdominal circumference of the fetus is too small or too large. So I think what's happening now with many of the birth workers in this country, we're getting quite cocky with our ability to persuade someone to do something, and the something in this case is ending the pregnancy. So, okay.
Someone's got their mic on.
Is that better?
No, it's not you. Somebody, one of the delegates has got their mic on. Can everybody make sure they're muted, please?
Let me see. Is that better? Oh, that's better.
That's better. Sorry about that.
That's all right. It's brilliant. Right, so I just put it, this is a very simple, because I like to keep things simple for myself and for the people I look after. So I'll often pull up a picture like this and I'll say, which berries are ripe and ready? And you can see that there's some still on the bush that could do with picking, but the ones in the basket, there's something about them. We know, your mouth starts to water when you look at them. You just want to put them in your mouth, you know, they're nice, dark, and you can see that the berries are nice and plump, they're ready. And then you can look at the bush next to it and you can see why they aren't in the basket, some of them. you can see that they're a different colour. You can see that some of them look that if you were trying to get them off the bush, you'd really have to yank them. They won't just fall off in your hand or come off in your fingers like the ones that are in the basket. With pregnancy and childbirth, there's not a little screen that you can just open and have a look and see if the baby's ready. But we do have other tells, and some of us that are around a lot of spontaneous labour, we'll see them. We'll see the mood shift in the woman. That's normal. The cocktail of hormones is causing dopamine release, and all sorts of things are happening for the woman. So you can see that. Those of us that are around spontaneously can see that. Another thing that we sometimes see, because of vasoconstriction and vasodilation, you can sometimes see a change in the woman's blood pressure. If you're one of those continuity carers, you can see that you've been taking her BP whenever you see her, and then you see it starts to creep up a bit, because progesterone starts to drop. So the progesterone starts to dive, and then it means that her blood vessels that previously have been quite lax start to get some of their tone again. So it pushes the blood pressure up just a bit, not into a pathological range. You just see it climbing, and that woman's going to give birth soon. Progesterone has to drop, because then the oxytocin can work on the uterine muscles effectively. Progesterone makes uterine muscle relax. So we need it so that it's there in huge amounts so that the person can stay pregnant. But once the pregnancy is coming towards its end, because the baby sent its signals and the mother's body is responding to those signals, then you start to see these hormonal physiological changes. We need to be able to spot that and recognize that and trust it. The pregnancy is coming to an end. The woman starts to become a bit more juicy. So she starts to have more discharge. She might be more tearful. So there's loads of wonderful changes and shifts that we can see. Sometimes you'll physically see, like she may say around 37, 38 weeks, oh, my bra's feeling a bit tight, because she starts to expand so she can take all of those big breaths to carry her through her labour and birth. So we're supposed to be able to spot these things. And so it's easy with a basket of berries to see, yeah, they're ripe. To see if a woman or birthing person is ripe, you just need to be around enough of them to be able to see those signs and recognize those smells. And, her sleep may become a little bit more disturbed. That's her coming towards the end of her pregnancy. That's her body responding to the release of the baby, the release of the protein that the baby releases, to say, I'm ready now. My lungs are ready now. My digestive system is ready now. We need to be able to recognize that. So I did say before that I mentioned Squaring the Circle. And the reason why I need to mention this book is because particularly there's so many chapters that are amazing. But the one, chapter 2, the title of that chapter, Nature and Consequences of Oxytocin and Other Neurohormones During the Perinatal Period. So, sounds like a mouthful, so worth wading through. And it's not many pages, but it's bringing so much expert information. So, even if those that like to work more on the high dependency side, may be more familiar with the various interventions that can be brought about to end a pregnancy, they should also be very interested in this chapter, because it talks a lot about, well, I'll give you an example of what it talks about. I'll go on to the next page. You can see, this is just like the first page. Talks about the oxytocin that's produced within the hypothalamus. Talks about the release, that the oxytocin promotes the release of dopamine, pain relievers, and associated pleasure and reward pathways. Talks about the HPA axis. Talks about the sympathetic nervous system, and then the parasympathetic nervous system that's stimulated by the pressure of the baby going down, descending. The further the baby goes down, the more oxytocin is released, the more the uterus contracts. we need to know these things before we interfere with them, for goodness sake. If we're going to do families a favour by promoting physiological birth, because it has better outcomes, not just physically, but psychologically for the family, there's less trauma. If we're able to affect that for families, when there's a genuine need to intervene, it will seriously be for this tiny minority. It will be for the minority. And if it's for the minority, then that means we've got a lower chance of having these huge negligence payouts. We need less doctors on the floor being called in to do these emergency cesareans that are raising, the rate is rising day by day. And then we've got the associated knock-ons from that. We need to be thinking again about, how do we as professionals recognize what is happening in a woman, why it's happening, the role that the baby plays in what is happening? We need to be able to understand that. And then I'm fairly certain that we will have the will to wait. We will have the will to wait. Just wanted to also say, why is it that we are, well, not we, those in my hearing, but as a profession, midwives, why have we got to this place where we are so willing to let go of what is physiological? And I know the ultimate thing will be fear what happens to us, fear of loss of respect from our colleagues, fear from what could happen with regard to sanctions. If we're on the register, Nursing Midwifery Council, fear of what will happen there, fear of lack of support from our colleagues, fear of poor outcomes. We have a lot of those things. Whilst I'm actually thinking, how about we bring respect into the picture? Respect of the one giving birth, respecting the one being born, because what happens to the mother, the parent, something is happening to the child inside. So we need respect for the one being born and respecting the process. If we don't understand the process, how can we respect it? I'm guessing is where some people are coming from. Where I came from when I started my journey with midwifery was, well, if babies have been born for many thousands of years without obstetric expertise, you know, we're all here today because birth works. So if I'm coming into a career where I'm actually seeing that women and birthing people have the ability to birth, if we can wait, then why would I do anything other than wait? Why would I insist on maybe doing a membrane sweep because of a calendar, because of how long that woman's been pregnant? Why would I insist on maybe scaring her partner into scaring her into accepting my recommendations of bringing about the close of the pregnancy? Why would I do that? I come from a point of view of less is more. If I see a woman and her baby and they're healthy, I'm not going to make a single recommendation. If there's something that's presenting to me that's saying this woman or this baby or both could do with some help, then I would make a recommendation. I definitely would not look at a calendar and make a recommendation. Things that sometimes, if a woman says, she's in her 42nd week and she's complaining about various pains, I'll think about that. I'll think about the physiology. I'll think about the position of the baby inside of her. I'll think about her mood, who's around her, who's talking to her, what stories has she heard lately, what is she eating, how is she sleeping, how is she sitting. I would be looking at all of those things and then having conversations around that before I say, okay, let's just see if we can just fire this baby out of you. Because if I was to recommend that, okay, let me just poke around with your cervix and see what we can do there, I'm ignoring the fact that if there's a malposition, all I'm doing is setting her up for a very long journey with a baby in a malposition. Why would I do that? See, that's why I'm saying, like, I call myself a birthkeeper now, and it took me a long time to accept the role. A mother called me that first, and she actually gave me a book. about birth keepers. And she said, I think this is you. And I had a read and I thought, yeah, it might be me, because I do have respect for this process and I have an understanding of it, not as detailed as, you know, many people that are scientifically working within childbirth. They just amaze me. But I know enough to know how to support the unfolding of it in a physiological way. So I would consider that I'm doing a disservice to families if I was to recommend anything that's crude, like, let me poke around with your cervix, let's see what can happen. Let me put an artificial form of prostaglandin up at your cervix, let's see what it can do. I'm disrespecting all the other aspects of physiological birth that need to unfold. What mood is the woman in? What mood is she in? Is she in the mood to labour and birth and then bring her child to the breast afterwards? Some women won't go into labour if they're ill. So if they've got a cough or a cold or feeling a bit fluey, the labour won't start. If their partners are ill, labour won't start. You see, it's all these nuances that we need to know as practitioners to be able to keep a family from going down unnecessary pathways. We need to be able to understand that. And so have I got 5 minutes yet? How long have I got?
Just checking, you've got 10 minutes actually, 10 minutes, 13 minutes to be perfectly precise.
Do you want me to allow time for questions?
You could, I mean, there is a discussion, you know, a time for discussion. So it's up to you, Kemi. You know, you can either do it now, and then we could have anything that flows over into this session at 12, or you could talk up till 12. Up to you.
Okay. All right then. I'll keep talking then, because I can talk a lot.
Okay. So I'll give you a 2-minute warning then.
Thank you. Thank you. So, thinking about the process of continuity and the part it plays in physiological birth. When I meet couples, try and find out, what are they eating? Do they have any pre-existing health conditions that can affect things that they can do? You know, like the questions, because in actual fact, when I was, you know, being taught midwifery and I was working in the services, we'd have a long questionnaire for booking. And I remember being on the register and still not quite understanding the need for all these questions. And now I can quite see them, like the questions about whether you've had any broken bones, you know, the question about have you ever had damage to your pelvis, etc. I know I should have understood, but I was on the register not quite understanding why. And then as soon as you start working with families, it all unfolds. So you want to know, you know, have they fallen off a horse? Have they got inflammation around the coccyx or the sacrum? You want to know, could there be instability in the pelvis, in which case, you know, I call other practitioners that work with women that are not midwives, I also call them birth keepers. There's some birth keeper obstetricians, you know, they're doing their absolute best to promote the physiology of childbirth. So it might be that they need to see a chiropractor, or my favourite offer is a Bowen therapist. So we start to think about those things during the pregnancy. Okay, what are your cravings? Let's think about that. You're having recurrent thrush. Let's think about, what are you eating? Are you a bit on the sugary side? Are you into your cake? How does your body, like when you're around 34, 36 weeks and your body's screaming for carbs, how do you answer that scream? So that's why, you know, continuity is so good. You can just walk that path with them and encourage them in their pregnancy to set themselves up for a really good labour and birth. Which way are you sleeping at night? Are you sleeping on your right because your husband's on your right or your partner's on your right? Okay, so you might need to swap over sides on the bed so that you can now sleep on your left. Are you sleeping on your left for the whole pregnancy? Don't do that. Why are you doing that? You only need to do it from the 3rd trimester. That's been shown in research. So you get to do that walk with them so that you're promoting the physiology of childbirth all the way through the antenatal walk with your families. So what we're hoping to have is an aligned baby in a balanced pelvis, in a balanced woman who hasn't been in pain or, you know, having, you know, all sorts of neuro joint issues. We want a woman that's well balanced, that's healthy and stretchy. So thinking about what's her movement like? Does she use a gym ball? What is she sitting on when she's working? How long is she sitting? And like, we know that sitting is probably the worst thing that's ever happened to our society, to humanity, is the chair. So, you know, we just have those discussions with the birthing person, you know, thinking about how much rest are you getting? Who's stressing you out? Because remember, this is a hormonal thing. This is kicked off by hormones. So you've got to think, who's stressing you out? What's stressing you out? Why? Stress is a thing that happens in pregnancy anyway. The amygdala kind of just goes all haywire of a woman who's pregnant, and so she starts to fear lots more things than she would have done when she wasn't pregnant. She becomes more compliant just for herself to feel safe. The oxytocin starts her on a tend and befriend mission. Who's going to be with me and look after me when I'm giving birth? So all of that is happening. So we as birth keepers need to try and answer as many questions as possible and keep her balanced and in that place where she feels confident and has trust in the people that are around her. So then the baby releases its protein because it's ready, and the woman's body responds. And then we've got to be able to help her with that response, because she might start really acknowledging her Braxton Hicks. Got to reassure her of that. It's not false labour. This is her body toning and getting ready for birth. She might be experiencing some more wobbliness, say, in her pelvis, particularly at the front. So she might find those two bones at the front and the cartilage that's joining them, you know, and then she starts talking about pelvic girdle pain. So we want to be able to help her with that and make suggestions. And this is all leading towards her being able to let the birth unfold in a physiological way. So some of us can provide, I usually provide lots of articles, some evidence that I've seen, etc., which also adds to that feeling safe for her partner. If her partner's feeling wobbly and unsafe and traumatized, then she will pick up on it and it will affect her physiology. So we keep doing that. Then it comes up to the time of birthing. You know, Margaret here, she's done so much work, and I've got her amazing book about birth positions, because we know that if you're on the bones that are meant to move back and to let the baby descend and be born, if you're on that sacrum and coccyx, if you actually got your weight on it in a semi-supine position, then that's not going to be able to work. We've even got people making videos of putting pressure on the sacrum, sacral pressure. But again, you're pushing back against a baby that's trying to move it out. So you've then got more videos of yoga teachers talking about people doing deep squats to help the baby be born. You know, all of this misinformation, all that's doing is causing deep transverse arrest for more women, which is scuppering the physiological birth process. But then thankfully, the antidote, you've got Margaret and others that are producing excellent work about how to promote physiological birth using positions. You've got Margaret's birth chair. You know, those of us that work in labour with women will always be facilitating them to be upright, forward and open. So we're all doing our bit. We're all
somebody's mute. Can everybody make sure they're muted, please?
We here in the group, if we've got doulas here as well, we're all doing our best to, you know, facilitate birth in water, which also helps to keep the bones free, helps the woman to have relaxed bones, not to be referring any kind of pressure elsewhere, so that the baby can descend in a balanced way and do their rotations and deflex their head and be born. So thinking about, you know, promoting that during birth, we're also thinking about the release of hormones, the way light affects the release of oxytocin, noise, her being cold, you know, all of these things. We want to facilitate her optimal release of the right hormones for the birth. So we don't want her to be cold, we don't want her to be frightened, no shiny instruments, no sharp noises, no strangers. We want all of that to come together to promote physiological birth. And then we know as well, because, you know, although being pregnant feels like a lifetime, you are in your postpartum period for a lifetime. So what happens postpartum, the effects on all of the antenatal preparation and the conduct during birth, sets the person up, the birthing person up, when they've given birth, so that they can feed their baby, nourish their baby by their breasts. So if they have wounds, they've got optimal time for wound healing, so that we can make suggestions like the first 40 days, spending a lot of time resting and nourishing and being warmed, so that that woman can then recover from her birth experience in good health, in preparation for the next one, if she should choose to have one. I was affected because I didn't do any of those things. My menopause hit me like a train, and my health between my births and my menopause was always rocky because I didn't look after myself postpartum. So we really want them to be recovering from a physiological birth, because that way they're going to end up in their best health for subsequent births and for life ongoing. If they have a birth that has intervention in it, particularly induction, then they have a lot more to recover from in most cases, because the birth is not going to unfold in an efficient way as it would if she'd waited for spontaneous labour. So
Kemi, 2 minutes. Okay.
2 minutes. So just to say, with all my ramble, that physiological labour and birth appears to be the most satisfying way for people to birth. They bring their children to their breasts, and those that choose to breastfeed, if they haven't got wounds to recover from, will breastfeed at their best. They will have, their body will be able to just give itself over to bonding and breastfeeding, which is a situation that endures for them. For some people it's months, weeks, some people it's years that they have that experience of breastfeeding their child, which all adds to the bonding experience, which all adds to the health of the child, the future health of that person, and how they give birth. So that's my bid for trying to get everyone to get that respect for the process involved, so that we can then give our best to the people in our care and their little ones.